And at that time, people used to always think that pediatric endocrinology is one branch, which is basically very, very rare, dealing with rare, complicated disorder, which require cumbersome evaluation and expensive treatment. This was a common thing. Everybody used to say, what will pediatric endocrinology do? Nothing much to be done this there. But when we started seeing patients, we were shocked by the way they were being managed. And this is one case with Dr. Rashmi and both of us managed. It was a very short child diagnosed in 10 years with severe anemia, presented for the first time. And then at that point of time, there was a short stature and was given a blood transfusion, diagnosed as a case of celiac disease, but unfortunately had developed HIV because of the blood transfusion which happened in that scenario. So this was an unfortunate scenario, a case which should have been diagnosed at the right time and should have been managed in that perspective, always in that scenario. So we thought, what are the problem? Is it a problem of awareness, accessibility, or affordability? Now everybody says it is always a problem of cost. So people say cost is a major problem. But what is the truth is actually the elephant of the house is awareness. If you don't know when should you go, where should you go, how you should be managed, it is difficult. Once you go, direction is there, people will help you. People will help the patient will help themselves, but most important is awareness. So from there, we started our program, and 2012, we had the first PPEC, and a lot of people here, including all the seniors, Dr. Subrato, Dr. Rishi, everybody was part of that program. And since then, we have conducted huge number of programs across the region in the country. But unfortunately, how many physical programs one can do, that is a limit to that. So we started the advanced programs as well. So we moved forward from there to internet media, because now internet is available. So we started on YouTube around 7 years ago. And from there, we moved forward towards a structured program, both on-site as well as online. And now we have got the application and other things which are happening. We have e-learning program, which has got huge number of subscribers, and all of you would have accessed that. This would be something to go forward. But problem with YouTube is that you can see one video and then you forget about it. So if you want to have a systematic learning, we started off with this program of MedEClasses 4 years ago, in which we now have a fellowship program and a diploma program. A lot of programs are there. A lot of people are part of that program as well. Now, we also run regular postgraduate fellow classes, and the publications and applications are there. Applications are going to make very easy day-to-day management in that regards. The often problem which still remains is that the number of pediatric endocrinologists in the country may be around 100, and 100 may be an overrating, exaggeration. Cases are thousands. So what do we need to do? There needs to be a bridge between cases, pediatricians, and pediatricians with special interest, and then more pediatric endocrinologists. This is what we are looking at. For that, now we are trying to come up with a solution, which hopefully will come up in the next 2 to 3 months, which will help you out using a personalized, intelligent EMR. Now, what it will do is that based upon your particular problem, so if a child has short stature, once you say short stature, specific questions will come with regards to history, examination. This will be there for all conditions. So precocious puberty, delayed puberty, DSD, whatever, 40 conditions we are developing these protocols. You just have to enter these data. Once you enter, you will ask specific questions in examination. So for a delayed puberty, it will ask anosmia. For precocious puberty, it will ask about headache. So different questions will come. Once you answer those questions, put basic data while you are examining the patient. This is looking very benign, simple. You're just putting. But what is, and you can simultaneously assess bone age there. So it looks very simple, you're doing that. But what is happening is that behind the scene, algorithms are running, which are then telling you this is the diagnosis, this is the investigations required, this is the likely treatment, and then you will get a lot of output. And you can then export it in the form of a proper, it will give you like a proper history has been taken, you will get results, interpretation. This is a work in progress, lot of intelligent algorithms required. It will take time, but this is the way forward. So this will allow everywhere across the country to have a state-of-the-art, quality assured sort of a management, and then there could be connections with clinics as well. So this is something which we are working in that direction. Last 3 days, we had very intense program in the Regency Center for Diabetes, Endocrinology and Research. Over 30 people from across the country had come, and it was a very good interaction with over 300 cases. in which a lot of interactive discussion. Type 1 diabetes, everybody has talked, is a never-ending saga. A lot of developments happening, but every time ye dil mange more. Every time we want more new developments to happen in that perspective. So what really we want? We want a system which is actually able to assess and detect hypoglycemia or hyperglycemia, react accordingly. When required, it will be able to secrete insulin. When required, stop insulin. When required, give glucagon. So we are sensing as well as response both for hypo as well as hyperglycemia. First of all, we want to prevent diabetes. We preserve the beta cell function and then finally restore the beta cell function. These are also the goal which we want to do in that setting. Now, what are the problems? You can never have a portal delivery of insulin because we are having the pumps in the subcutaneous. It goes in the blood and then in the liver. So portal delivery is impossible. That is something, a big challenge which is there. We want a seamless sensing. There is often a lag between by the time your capillary glucose matches with your actual blood glucose. So there's a lag there. Then your pump has a lag. So if you have so much lag, there will always be confusion as to achieve a good control. So we'll see what has been achieved and what needs to be done in that direction. So I'll start off with this case. There are twins, Sita and Geeta. Sita at 7 years is diagnosed as diabetes with DK. Now parents are very concerned what will happen to a younger girl on follow-up. So what can we do? Can we predict it in a manner? And if we can predict it, can we prevent it? So now we have done antibody status and studies have shown that we can predict very well whether this child will go on in developing diabetes. Now already multiple antibodies are positive. Insulin is low. There is a 5-year risk is 90%. Now what can we do to prevent diabetes? Because if we can't prevent, what is the point in predicting? So for prevention, there have been multiple studies which have been done. For primary prevention, starting from gluten-free diet to hydrolyzed formula to DHA, all of them have been found to be unsuccessful. For secondary prevention, once diabetes has maybe started, talk about insulin for sensitization, nicotinamide, all have been found to be unsuccessful. So right now we can predict but not prevent diabetes. So don't worry about 4% chance in siblings. If it is there, let it, we will handle it and manage accordingly. On 2 months follow-up, her dose is much less. So she is now on a honeymoon phase. There is a preserved C-peptide. Now the question is, can we prolong this honeymoon phase? If we are able to prolong the honeymoon phase, that is also good. Quality of life will be better. Hypoglycemia will be less. So there are trials specifically with anti-CD3 which have been found to be effective. But just to prolong for a few months, would you like to give us such an agent which is an anti-CD3? I think that's not something anybody will do. So at the moment, again, prolongation of honeymoon phase is also not going to work. So this is something which is not working, and all these studies are also not yielding any results. So next question is, she is now 1 year on follow-up. She does not want to go for insulin. What are the options? So we are talking about Afrezza. So Afrezza basically the inhaled insulin. The problem with that is that there are a lot of issues about availability, bioavailability, and the quantum doses are huge. So you can't say 4 unit, 8 unit. What about 5 unit, 6 unit? You can't give it. And it is only going to work as a bolus insulin. It is not going to work as a basal insulin. So I don't see a future of inhaled insulin at the moment. There are other talks about oral insulin. That also is not working. Biocon has been working on oral insulin for a long time. Nothing yet has come. So now the question is, can we use non-insulin drug options in the management of type 1 diabetes? So the option which can be used, metformin. Yes, insulin is not there. You're giving outside. You can sensitize the child with that. Amylin. Amylin is a drug which is approved in adults. It will delay the gastric empty. What about the GLP-1? Sulfonylurea, of course, not going to work because you don't have any insulin. What about GLP-1 receptor analog? Definitely a potential, especially because it is working on other pathways. It is working on the brain to cause satiety. It is working on the stomach to delay the gastric emptying. So there is a chance you can use it. DPP-4 inhibitors, no, because you don't have any insulin. Glucosidase inhibitors, Very mild drug, I wouldn't be thinking much about that. SGLT2 inhibitor, lot of potential. This is an insulin independent way. You are increasing urinary excretion. So even if you don't have insulin, it will work. But the problem is it will lower your glucose, but will not give you insulin. So you will remain insulopenic, and what quote unquote euglycemic decay may happen in this condition. So you have to be very, very cautious with the use of these drugs. So frankly speaking, metformin in obese, NAFLD, PCOS, that is one situation you can think of. Probably similar situation, GLP-1 receptor analog, plus minus, you need more evidence. And SGLT2 inhibitor, very, very cautiously, are things which you can consider. So what about the other options which have been used till now in that regard? So there is a trial on metformin. Again, obese individuals with NAFLD and PCOD. Only 3 indications. Don't give metformin in a lean individual. That will cause a huge problem, and that too adolescent. 14, 15 years, not before 12 years, definitely. We will not give. GLP-1 agonist, lot of work is going on, and with oral agents coming in, hopefully new research will come up. It will cause 3 to 5 kg weight loss, which is good. So if you have an obese individual, it is good. Otherwise, probably you will reduce the dose of insulin, but not too much benefit in HbA1c. What about sotagliflozin? Now, sotagliflozin is unique. It is a dual SGLT2 and SGLT1 inhibitor. So this can be an agent which can be helpful, but again, the risk of euglycemic decay is there. So if you are not giving enough insulin, the child is at risk of decay. So first, ensure insulin, then give this, and then maybe 10-15% reduction in insulin you may expect. Don't expect it as a replacement. So all these agents are sidekicks. They are not really the primary agent. They are not going to stop insulin. Definitely in that regards. Now, what options we have are insulin pumps. So ISPAD has now said that any age, any child is a good candidate for insulin pump. You don't say, okay, this age has to be there. This child has got this. So at any age it can be used. But very importantly, the family has to be motivated. They would need to know the cost. They should bear the cost. Otherwise, you start and then there's no benefit in that regards. Studies have shown that pump reduce HbA1c, lower hypoglycemia, more time in range, and less decay. So there are benefits. But don't expect dramatic decrease in HbA1c. If the family is not monitoring well, HbA1c may actually go up. So you have to be cautious with the use of pump, and good correction is required. Now we have all been talking about the closed loop journey, and now we have got the 780G, which a lot of you had actually experienced in the morning, which is trying to bring it as close to what we wanted in the first slide. So it is basically what it is doing is that it is actually detecting, then it is analyzing. Based on analyzing, it is delivering, it is changing the basal rates, it is changing the way bolus is being given. So in a way, it is working like an artificial intelligence closed loop, which is something which is desirable, very good, improves time in range. But again, everything is not perfect, so we have to be a bit cautious in that regard. Very importantly, it is recommended beyond 7 years of age and somebody who is on a reasonable weight dose on that. So this is something for children, something which can be used. Again, cost is an issue and sensor cost is an issue. But otherwise, studies have shown that you will achieve a very good amount of time in range, up to 80%, many studies have shown. It provides auto basal. So it automatically keep on changing the basal insulin based upon how your sugars are. So it's a very good way to go forward, and you can set your target. Best is to set target of around 120 initially, then go back to 100. You will get a good control in that scenario. So this is how auto basal works. Based upon sugars, the basal will go up and down. So this is much better. Lantus, you have given one dose. U300, Degludec, you have given one dose, you can't change. Here, automatically it is changing. So this is something which is good. And there are specific algorithms which will then predict the risk of hyperglycemia and change accordingly. So this is a nice way to go and manage in that, and good time and range can be achieved. But of course, cost, sensor, you have a sensor, you have a pump, and you have to change the sensor, change the pump. So pain and all those issues will also be relevant in that regard. So now if you have a child who wants cure, what do you do in terms of cure? That is a big question. So there are now restorative strategies, two types, pancreatic transplant, out of question. For pancreatic transplant, you will need to give immunosuppression. So only if somebody is going for renal transplant, think of it. Otherwise, this is useless. What about beta cell transplant, islet cell transplant? Again, require immunosuppression. Not a cure, just a prolongation of your honeymoon phase. Not very good. We are looking at stem cell transplant. Again, experimental. A lot of people come, okay, this center does stem cell transplant. So I always tell that whenever anybody discovers a treatment for diabetes, they will get the Nobel Prize next year. So don't go for all these claims. China, India, a lot of places they say stem cells. So this is all a hoax in that scenario, in that regard. Now there have been a lot of work which has been gone in terms of bioprinting, so 3D printing in terms of, so you may actually go and order beta cells for you in future. You can say, okay, I want so many beta cells, they will be printed and you will get it. Problem is they will again be damaged because antibodies will kill them. So you want a system in which insulin can go out, oxygen can come in, but antibody doesn't come in. So there are ways people are trying to design encapsulated forms in which you can actually have a porosity which will determine the oxygen, the insulin will go out, but nothing else comes out which may help. So again, work for future. Not much is done in that regards. Lot of work was done about beta trophin, which apparently increases the beta cell mass, but again, it was not found to be proven on subsequent studies. So whenever we talk about diabetes future, we often talk about 2 steps forward and then 4 steps backwards. And I remember very well that my professor in Australia, Professor George Werther, used to say that right from 70s, people ask, when will cure come in? You always say next 10 years. And since then, every 10 years, we have been saying next 10 years. So this is not an easy disease. Don't expect much cure. So probably what we are looking at, improvement in technology, which will be the way forward rather than a miracle cure, which may happen. Now, the other big issue is about the use of technology and how technology can improve. Now, we all know that patients are living in a different areas and everybody can't afford pumps. They can't afford, they don't even have knowledge. So how do we impart their knowledge of day-to-day practice? That also is important. So we can use different applications which allow remote monitoring, remote education. Patients can say, okay, this is the sugar, what do I do? They can immediately manage on that. And telemedicine has now also opened tools in that regard. We have developed specific tools for the doctors in the form of a mobile application to calculate the doses, correction, and sick day. And we are also coming up with a patient tools in multiple languages so that once they know what is their sugar, how much they want to do. So this will day-to-day help it out. So while we are talking about technology in the form of pumps, in the form of CGMS, in the form of other things, technology can also be used to allow simple things which may be life-saving in that regard. And one of the things which we developed, which has really been proven to be effective, is our DKA tool. So we discussed in the morning that we did studies which showed that protocol deviations are common in DKA and that cause problems of hypoglycemia and other issues because expertise are not available. So we have developed a specific mobile application which allows the personalized management of diabetic ketoacidosis. You have to feed some basic inputs and based upon those inputs, you will find a validated information about what fluid to give, which duration, how frequently, how to monitor, and this we have shown to be effective in improving quality management of DKA. So technology is a way forward. We have to consider on both the spectrum of India and Bharat. Both of them have different needs and we have to go for both aspects. So while pumps and all those things are there, they will always be used by a minority, a very small minority. We have to think of other people, how we can improve lives with simple technology, and there also technology is going to help us subsequently in that scenario. So I think now we have got so many things we can now predict but not prevent. We can monitor. Dr. Subrata talked about very well. Replacement, again, smart pens are coming up, newer insulins are coming up, closed loop is coming up, non-insulin options are sidekicks which are there. Restoration, islet packaging, I said, but these are all more of science fiction at the moment than the actual ones. And then 3D bioprinting and stem cells. And of course, there is a role of technology which is there. So there are various things which are going to happen over the next 5-10 years, but definitely it's going to be an incremental one. It's going to be 1, 2, 3, not 0 to 1. I don't expect 0 to 1 immediately in diabetes, but there are ways things will improve overall.